Welcome to Module 5 of the Tobacco-Free Futures Implementation Series, Specific Care Settings and Specific Populations. Tobacco-Free Futures is an integrated health systems tobacco cessation model developed for Alberta Health Services to provide support for Albertans who use tobacco products. This is the final module and refers to the content found in Chapters 14 to 20 of the Tobacco-Free Futures Guidelines. This final module will focus on potential considerations depending on your care setting and the populations you are dealing with when you implement the Tobacco-Free Futures Guidelines in your site or program.
Brief intervention, or the 5 A's, is applicable to all populations. What we've done is realize that there is a need to make some adaptation or changes for certain special populations. And so we have developed components for those special populations.
Chapters 14 to 18 address specific care settings. Let's start with Chapter 14, which addresses tobacco cessation in surgical care. All elective patients who smoke should be directed to resources to help quit smoking prior to admission to hospital, and all patients should be given information about how cessation prior to surgery can make recovery quicker and easier. Pre-admission clinics are ideal locations for brief tobacco interventions. For more information, refer to this chapter of the guidelines.
Tobacco is a key modifiable risk factor for disease. If we can encourage our patients to quit smoking, then we can prolong their lives and improve their general state of health. With respect to surgery, quitting tobacco enhances wound healing, reduces the possibility of infection, and enhances recovery from surgery. Hospitalization is an opportunity for us to intervene and assist patients who may be considering their health at that particular time more than other times. So it's an ideal opportunity for us to help and assist.
Let's move on to Chapter 15, Emergency and Urgent Care. Emergency departments are an underutilized setting to support tobacco users. Although EDs deal with many patient visits for life-threatening emergencies for which brief tobacco intervention would not be appropriate, a considerable number of tobacco-using patients are present for non-emergent health care. For non-emergent patients, minimal contact strategies, such as a brief tobacco intervention, should become part of an ED's routine practice. It's also an important opportunity to discuss the effects of secondhand smoke on children with parents and caregivers.
At our Rapid Access Cardiology Clinic, I get opportunity to see lots of patients. About a week or two ago, I saw a patient who had chest pain. They were in the mid-30s and they were a smoker. And, after all of my assessments, determined that the patient didn't have cardiovascular disease. But I spent the extra time talking to them about the fact that even though now they don't have cardiovascular disease, if they continue on the course that they have with continued use of tobacco products, that in 10 or 20 years, they'd be coming back to me with cardiovascular disease. And what was it that we could do today to help prevent that from happening? They had a good scare now where they didn't have cardiovascular disease, which is fantastic. But now how do we prevent that next visit not being a heart attack or a need for an angioplasty or something like that? Because we see that. And the people that we see that have young cardiovascular disease, those patients in their 20s and 30s and early 40s, are either smokers, diabetics, or diabetics who smoke. Opportune time, because they've had a good scare. And they seem very receptive to that fact. And so it's really important that we as healthcare professionals take those opportunities to help the patients at the opportune times.
For more information about implementing this initiative in your emergency or urgent care setting, please refer to Chapter 15 of the Guidelines. Chapter 16 provides information about integration of tobacco treatment in home care programs. Healthcare professionals working in community and home settings have an important opportunity to identify tobacco use and provide advice and support to their clients. Visits provide a window of opportunity and often teachable moments, especially when the client is being treated for diseases and conditions that are related to and significantly affected by tobacco use. This is often the case as many clients in this setting are receiving wound care or treatments related to diabetes, COPD, and other chronic illnesses. For more information, refer to Chapter 16 in the guidelines. Let's move on to Chapter 17, which talks about integrating tobacco intervention as a standard of care within public health programs and services, including, but not limited to, preconception care, prenatal care, postnatal care, well child clinics, early childhood development, school health, dental health, adult immunization, and communicable disease control. Management at Public Health Services will need to make decisions about integrating brief tobacco intervention within its specific programs and services, as well as standards for staff training. Please refer to Chapter 17 for the modified care pathway, treatment model considerations for this setting, and information on how documentation has been modified for the electronic client records called Meditech that are used in the South, Central, and North zones. The last of the specific care settings chapters is Chapter 18, Transitional and Continuing Care. There is a trend across Canada and in Alberta towards care facilities being tobacco-free. Clients who use tobacco products are increasingly difficult to place due to the decreasing number of available spaces and settings that allow tobacco use on the property.
Another challenge that we've identified as a healthcare system is with our aging population and the particular persons who are waiting placement in continuing care or transitional care beds have continued to use tobacco, that there's fewer and fewer places for them to go. So if somebody has smoked for all their life, what benefit is for them to stop quitting when they're age 60 or 65? There are benefits for persons to stop smoking regardless of their age. So, if we look at older people past the age of 65 and that when they stop smoking, that's one of the things that, really the only thing that they can be doing to prevent further progression of their chronic obstructive pulmonary disease. As well, there are benefits with regards to their mental status and preventing or reducing the progression of their dementia. They also immediately reduce their risk of myocardial infarction when they stop smoking.
Transition units provide a stopgap for clients who are awaiting placement in a continuing care setting that is more appropriate for their care needs. Health professionals working in community, transition, and continuing care settings have an important opportunity to identify tobacco use and provide advice and supportive care to their patients and clients. All patients and clients in acute care who are awaiting placement should be given access to a safe and comfortable detoxification from tobacco, as is done with other addicting substances, to prevent the emergence of nicotine withdrawal symptoms. For more information, refer to Chapter 18 of the guidelines. Chapters 19 and 20 address the unique considerations related to tobacco use and treatment within specific populations, including those with addictions and mental health conditions, as well as women and girls in the reproductive years. These important groups have not seen the significant reductions in prevalence rates that is reflected in the general population. In the United States, it is reported nearly half of all cigarette consumption is among people with psychiatric and substance abuse disorders. This population is 2 to 4 times as likely to smoke than the general population.
Probably the greatest number of people who continue to smoke, and especially heavy smokers, are people who also have addiction and mental health problems. So they're the people who come to see us in addiction and mental health, and we have historically not seen them as people who find it easy to quit, so we've focused on other problems. The problem with that is that, let's take somebody with schizophrenia, and the rates for smoking in schizophrenia are very high. The diagnosis of schizophrenia gives you a shorter lifespan by approximately 20 to 25 years. Fully half of that life loss is due to smoking. So we are, in essence, complacent with an early death for the people that we work with unless we give them the best chance possible to quit. So that's why I think this is critical. We know that people with addiction mental health problems have very similar levels of motivation to quit to other people in the population. They may have struggles with that for lots of reasons, but we know that the people who succeed in quitting are the people who keep trying. And our job then is to try and say, is this a time that we might try and help you do that, to try and support them in that? And if it doesn't work out this time, to say, there's the next time as well. People who have addiction mental health problems are no more likely to be smoking than anybody else in the population, and we've got a fair ways to go.
Tobacco use has long been accepted as part of the culture of care in addictions and mental health treatment. There is strong evidence that tobacco use is closely linked to severe mental illness and has a major detrimental impact on individuals' lives. These individuals die on average 25 years prematurely, with the leading causes being chronic tobacco-related diseases.
Ask, listen to their story about smoking, offer support, and help them in a way of moving into the desire to quit smoking. Use a little bit of motivational interviewing. And if they're not interested, don't put it aside permanently. Bring it up again and again at different times. Really believe that your client can quit smoking. I think we need to be more optimistic that that's possible for someone with a mental illness to quit smoking, because we know it can happen. Learn about the resources out there that you can refer your clients to, such as the Alberta Quit website, the smoking helpline, those things. Learn about the medications, what the aids are, what financial support they will get with that. And that's where we have to be a little more patient. We have to use the medications at higher dosages, and we all need to get educated on how to help them with that.
Over the years, we've realized as a group here that it's really important to address not just one addiction, but the fact that tobacco is a big part of the clients' lives here. And so research shows that if you can address the tobacco use at the same time as their other substance abuse, a lot of the success rates are increasing significantly. So that was basically the premise we came from.
There was a lot of fears around we're constantly going to be having to police it, that the clients are going to be trying to sneak around and use tobacco products. Is it going to become extra monitoring? Are we actually going to be able to even focus on doing addiction treatment, or are we going to be constantly having to help them through the different tobacco-related issues that are coming up? Clients themselves sometimes express fears coming in. I don't know if I'm going to be able to do this. It's going to be too overwhelming. I've always thought I should do one thing at a time. Even my doctor told me I should just focus on the alcohol, worry about the tobacco later. What we found is that the fears were really unfounded. We found that I think there's probably been, since we implemented about 10 months ago tobacco-free, I think there's been 2 or 3 clients who've left treatment prematurely. We have very, qualified staff who are able to support clients through the struggles.
Hopefully a good foundation for them to maintain that for the rest of their lives, right? Because, there's a huge cost associated with tobacco use, right? And in healthcare settings. And one of the things that comes up is that the tobacco use is more likely to kill someone than the other drugs of choice, right? So we could have people here doing whatever kind of stuff that brought them to us, right? And then they just continue to smoke, and then, that ends up costing them significantly, right? So for folks to be able to leave here clean, healthy, right? I think that's probably the primary goal of most addiction treatment facilities, right? So I think we're definitely achieving that. And as far as my role, it's just been a pleasure to be a part of it.
Please read Chapter 19 for more information about tobacco treatment for those with mental health and addiction disorders, including specific conditions such as dementia, anxiety disorders, depression, and schizophrenia. Chapter 20 is an overview of tobacco use in the reproductive years. there has been a drop in Alberta maternal smoking rates from 24.8% in 1999 to 13.8% in 2012. However, tobacco use and exposure continues to be a leading cause of adverse birth outcomes for newborns and a major cause of health problems for mothers. It is optimal to support men and women of reproductive age to become tobacco-free prior to a pregnancy. When that is not possible, it is important to note that when women quit smoking before the first prenatal visit, the risk of these complications can be reduced to the same levels as those of non-smokers. When approaching girls and women about using tobacco during pregnancy, healthcare providers need to use a women-centered approach to motivate pregnant women who smoke to quit for their own sake, not just that of their baby. Many women are motivated to quit during pregnancy. However, rates of relapse in the postpartum period are very high. In the absence of strong evidence to support the use of medication to assist pregnant and postpartum women to stop using tobacco, intensive cessation support, for example counseling, is commonly recommended as first-line treatment.
My area of interest for a number of years has been tobacco, the impact of smoking on the mother and the fetus and later development of the child. We need to move away from emphasizing on the fetus and the newborn and maybe swing it towards a mother or a woman-centered approach. Not too many things happen in isolation, so we need to look at the woman as a whole. So holistic approach, what the social issues are, what the domestic situation is there violence, are they underserviced or underserved population, what the education level is, what the income level is, what part do they live, does the spouse smoke, and equally if not more important is what the mental health, what are the side effects or the harmful effects of smoking are on their own health. And then come to the pregnancy, that during the pregnancy it can cause lots of complications. They may not even get pregnant because it reduces the ability to conceive. So conception may be less. Other issues are that they can have premature labor. The water can break earlier than it should. They can have a placental separation or the accident of the placenta, and then the premature birth is also happens. Another area is as the baby develops into an infant, there are issues with asthma, allergies, ear infection, neurodevelopmental problems like schooling. They don't do that well in school. So there are many issues.
For more detailed information about tobacco cessation during the reproductive years, which is not just during pregnancy and postpartum, please refer to Chapter 20 of the Tobacco-Free Futures Guidelines. Chapters 14 to 20 cover just some of the specific care settings and specific populations that may pose some unique considerations for implementation of tobacco treatment as a standard of care. A chapter that focuses on youth and families is under development, and other chapters may be added in the future. Tobacco-Free Futures Guidelines were developed as a resource for managers, tobacco steering committee members, and healthcare professionals in general to assist healthcare sites and programs integrate tobacco treatment as a standard of care. The Tobacco-Free Futures Implementation Series is intended to be a supportive tool to help highlight information found in the guidelines and give examples of context from sites and programs that have implemented this initiative.
The Tobacco-Free Futures provide a toolbox that healthcare professionals can use within their programs and sites to be able to offer the best possible care for their patients with tobacco dependency. And I encourage you to take advantage of that and to become a champion on your unit, within your site, to improve the care of persons with tobacco dependency.
Up to our leaders and staff to ensure that they do adopt those tools and resources to deal with this extremely important health problem that continues to be present in Alberta. I'd like to thank all of our staff for being part of this and for doing all that they've done so far. and look forward to ensuring that they continue to do so in the future.
Thank you for watching the Tobacco Free Futures Implementation Series.